Okay, we are pleased to welcome our next speaker, Alicia Gomes, who is a certified genetic counselor at the UAB, that's the University of Alabama Medical Genomics Laboratory, a world-known academic laboratory with a special interest in NF and mosaicism. As a laboratory genetic counselor, Alicia serves as a liaison between the laboratory, clinicians, and patients undergoing testing at UAB. In her presentation, she will speak about state-of-the-art of genetic testing. Welcome, Alicia.
Thank you. Okay, can everyone see my slides?
Yes.
Yes.
All right, so I just wanted to review some of the unique and complex testing approaches that are available in our laboratory, as well as other locations internationally that have been very helpful in confirming diagnoses of individuals with the neurofibromatosis. My only disclosure is that I am employed by this laboratory that performs this testing. And my goals today are to review these testing approaches, describe some of the benefits and limitations of using each one, and then highlight through some clinical scenarios where it would be best to use one approach over another. As a genetic counselor, I prefer to do this through a clinical scenario, so I'd like to start with this pedigree of a 7.5-year-old child who presents in a clinic with multiple cafe au lait spots and freckling. After a review of the family history, it was also mentioned that dad has cafe au lait spots, but does not technically meet clinical criteria for NF1. So of course, the primary concerns would be NF1 and Legius syndrome for this child. We have in our laboratory 2 testing approaches that can be done, one using germline, one using somatic testing. In the germline, testing can be performed via RNA for NF1 or via next generation sequencing. And this can be done as a single gene test or as a panel. For somatic testing, RNA-based testing is available via neurofibromas or cafe au lait spots, and we'll talk more about that later. So of course, I'd like to start with some important history about the progression of testing throughout the years. So in 2000, an RNA-based approach for NF1 was established. This was very important because before this time, truncating variants may have been able to be detected. There were some protein truncation testing approaches, but many of the cascade of variants that are seen in NF1 were being missed. Most importantly, deep intronic pathogenic splicing variants, in-frame and out-of-frame splicing variants, and rare complex mutation types. So our RNA-based testing approach starts with a fresh blood sample in a standard EDTA blood tube. From there, we do an RNA extraction. So this begins with a short-term lymphocyte culture. We use a specific reagent to help stop nonsense-mediated RNA decay. And then RT-PCR is performed to get cDNA, and this is what's done with Sanger sequencing to look for the various types of mutations that can be seen from this methodology. In complement, we also extract DNA directly, and MLPA is performed, as well as microsatellite marker analysis just for quality measures. And it also helps in confirming potential mosaicism as well. The DNA is also then used as a confirmation for any variants that are seen using RNA. And last, to complement, when there is concern for total gene deletion, FISH can be performed to see if that deletion is actually present at a low level. So this is just an example of an individual who has undergone RNA-based testing. The top picture here displays the RNA-based results. So as you can see, in this particular case, there's this entire exon that has been skipped. And so from the RNA, you can clearly see that this is deleterious and that there are concerns in the RNA that is produced from one of the alleles in this patient. On the gDNA-based side, however, it presents as just a single variant change. And in this particular case, it's a +1 G to A variant. As you can see, this can be of concern in trying to determine pathogenicity when the variant may be a missense variant, but having the complement of this RNA-based information to see the actual effect that the mutation is having helps us in classifying many of these variants. So one of the biggest pros for RNA-based testing is to lessen the number of variants of uncertain significance that can be found, as we're able to clearly see if they have any deleterious effects on the RNA that's produced. And we are also able to confirm or detect splicing defects, even in some mutation types that you would reclassify as just a simple nonsense or truncating variant. There are some abilities to detect rare and complex mutations as well. However, every testing approach has its own limitations. For RNA-based testing, there are some specimen stability issues, as either it requires a unique tube to test with, or for our approach, the sample must arrive within 60 to 72 hours. So depending from where in the world the specimen is coming from, this can rise as a challenge. It is also Sanger sequencing based. So because of that, there are some significant limitations in the ability to see a mutation present at a low level in those blood lymphocyte cells. Also, because of the multiple tiers of testing that are used, there can be a higher cost and complexity associated with this test. So in 2007, the SPRED1 gene was identified and known to be causative for Legius syndrome. Initially, we did this testing via RNA as well from 2007 to 2011, but it was important to note that there were no deep intronic splicing variants identified. And as a result, we found that it was just fine to perform SPRED1 testing via DNA only. So it is also some things that we've learned from our RNA-based testing approach is that there are very few recurrent pathogenic variants that are seen. More than 3,400 different variants have been identified out of the 9,800 unrelated NF1 positive individuals that have been seen as recurrent variants. 31 have a frequency of greater than 0.4%. So this can be a challenge when seeing novel missense and splice variants. RNA-based approach has been helpful in interrogating whether or not any of those missense variants are indeed splicing defects. And through this, we have also been able to identify more than 65 different deep intronic splicing defects, and they all they predominantly reside within the first 50 intronic base pairs that flank all the exons. There are others that are more far out, but we have also taken note of them. And through this information that we've learned from our RNA-based testing approach, we customized a next generation sequencing approach in 2016 that encompassed all of our known deep intronic splicing defects. So all of those more than 65 intronic regions that we had seen from the RNA-based testing that was being performed. We were also able to include via the next generation sequencing pipeline of the test, insertions, deletions, and duplications that were 112 base pairs or smaller. And we complement this testing with copy number analysis by MLPA or a bioinformatics pipeline so that we can also detect variant copy number analysis that are larger than 112 base pairs. Our deep coverage is what's been the biggest benefit of this next generation sequencing approach. So with an average coverage of about 1800x, we have been able to identify low-level mosaicism as low as 2 to 3% variant allele frequency. So this can be very helpful in confirming a potential diagnosis of mosaic NF1 in an individual where the mosaicism extends to the lymphocyte cells. So this is just a schematic of the workflow that we use as a part of our next generation sequencing. It is a haloplex workflow, which is important because it means that we are getting multiple reads of each of the regions that we would like to test, and they are all of variable size depending on which hybridization probes have been used and how long the ligation has been. So we use this next generation sequencing approach, not just for NF1, but we've also incorporated it for Legius syndrome and other overlapping disorders within the RASopathy related disorders. For GNAS for McEwen-Albright, especially given the concern of finding mosaic variants in this condition. Again, all of these include next generation sequencing and copy number analysis when deletions and duplications have been a part of that mutational spectrum. And this testing can be done from blood, saliva, and most recently neurofibromas. So the biggest pro is, of course, that this is deep coverage, so the ability to identify low-level variants. We have a lot more specimen versatility because now we can receive extracted DNA directly, which has been very helpful for some of our international clients. And we can identify known splicing defects without having to have RNA on hand. Of course, some of the cons is that some of the rare complex mutations can be missed, such as those retrotransposons or ALU insertions. However, we do anticipate that they represent less than 0.5% of the total mutational spectrum. So mosaicism has been able to be a benefit, so we felt like the benefits outweighed the limitations. Of course, this testing cannot detect mosaicism outside of lymphocyte cells. So if a mutation is present in just the neurofibromas or cafe-au-lait spots, for example, no matter how deep we go, we'll never see it. This is just an example of the reads that we get from our next generation sequencing approach. So as you can see in this specific location, we've been able to obtain multiple amplicons that represent the same location of various length, so we can feel more confident that when we only see 1 or 2 or 3 variants from each amplicon, that it's being seen over multiple amplicons in forward and reverse, that this is more likely to be a true variant and not an artifact. So this is just an example of a report that comes from that testing approach. So we're able to confirm the presence or absence of a variant in the same manner. And we can say specifically what our expected variant allele frequency will be. We do complement this testing with Sanger sequencing when the variant is expected to be mosaic. We also have some other technologies like melting curve analysis to try to help in confirming mutations that may be lower than what Sanger sequencing can detect. So let's switch gears just a little. And instead of focusing on the child, let's focus on the father, who we mentioned had a couple of cafe-au-lait spots, and perhaps he's concerned about his risk of transmitting NF1 to another child in the next generation. When it comes to detecting mosaicism, the gold standard approach is to test the neurocrest-derived cell lines. So for NF1, this would be the Schwann cells in the neurofibromas, and in cafe-au-lait spots, this would be the melanocyte cells. So to do so, we would need to culture specifically for the cell line in question, as both neurofibromas and cafe-au-lait spots contain quite a number of cell populations, but a culture is needed to specifically isolate the cell line of interest so that we can do direct testing on that material. So this is some pictures and information from the literature regarding how this testing came to be. And it's important to note that it's these melanocyte cells and the Schwann cells that have also shown 2 hits associated with NF1. in the melanocyte cells and in the Schwann cells. So as I mentioned, the biggest pro is that this would be the gold standard to confirm mosaicism, as we would see a common first hit, 2 unique second hits in this material associated with NF1, even if you cannot determine if the mutation is present in the blood. The cons, of course, is that this is an invasive process, as we would need a minimum of 2, ideally 3, anatomically unique biopsies in order to see a common first hit. This testing approach is indeed complex as well, as it requires a longer term culture to get that specific cell line of Schwann cells or melanocyte cells. Also, it takes a long time. So this testing has an average turnaround of about 6 months, specifically associated with the need to culture those cell lines. The testing can also be costly, as it involves quite a number of methodologies and procedures. So to switch gears, we will focus on NF2 and schwannomatosis. So let's address a new clinical scenario. In this particular case, we have a 48-year-old man who presents with a unilateral vestibular schwannoma, 4 cafe au lait spots, and 4 peripheral schwannomas. He has 1 son, age 23, who is noted to have a unilateral vestibular schwannoma, and another son, age 27, with a single nerve sheath tumor in his left foot. No pathology has been performed on that specimen. So of course, he wants to know if his family is at risk for a genetic disorder and what is going on. As Dr. Plotkin has already reviewed, so I won't go into a lot of detail. This is the current clinical benchmarks for gaining a diagnosis of NF2. And for schwannomatosis as well, I wanted to reiterate what has been seen in the tumors associated with these conditions. So for schwannomatosis specifically, instead of having 2 hits that are isolated to just 1 gene, there are 3 genes, NF2, SMARCB1, and LZTR1, that are all located on chromosome 22, and on the long arm of chromosome 22. And in tumors associated with schwannomatosis, we do expect 3 events that will impact all 3 genes in some way. The first hit is expected to be either a mutation in SMARCB1 or LZTR1. The second event is expected to be a long arm of chromosome 22 loss that takes out NF2, SMARCB1, and LZTR1. The third event is anticipated to be a pathogenic variant in NF2, and for each tumor that you test, the NF2 mutation changes. So when we have more than 1 tumor that can be tested, and we see a common first hit in SMARCB1 or LZTR1, we see an NF2 mutation that changes from tumor to tumor, and we see this long arm of chromosome 22 loss. From a genetics standpoint, this is our way to confirm a diagnosis of schwannomatosis. So for our testing approaches to look for a differential diagnosis for patients that meet criteria or have phenotype that is concerning for NF2 and schwannomatosis, we can do NF2 only, a schwannomatosis panel that includes NF2, SMARCB1, and LZTR1. There is meningiomatosis panel that also includes SMARCE1 and SUFU, and a peripheral nerve sheath tumor panel for those patients who have either a mixed hybrid-like tumor or no pathology has been done, so there's a concern that it may be a neurofibroma or a schwannoma. So for this testing approach, we can do it from blood or saliva or the tumor directly. For fresh and frozen tumor materials, this is done via next-generation sequencing. And from paraffin-embedded tumor specimens, this is done via Sanger sequencing. The DNA quality that you obtain from paraffin-embedded tumors is much lower. And as a result, Sanger sequencing is required to use shorter amplicons to get good reads and not have as many artifacts. So the primary question that I get as a laboratory genetic counselor is where to start. Should we start with blood? Should we start with tumor in these cases? And it's difficult to answer that in a general approach. And a lot of times we have to consider it on a case-by-case basis. The tumor may not always be available. However, it is the best option when you are concerned about mosaicism. This is especially true for NF2 if you have a patient who is of concern for NF2, but it's a sporadic case, for example. Tumor collection may need to be coordinated through multiple facilities or in conjunction with the patient's surgery, and sometimes that's just not easy to coordinate. The DNA quality, as I mentioned, it can be very difficult from tumor block material, and depending on the process that was used for the tumor block production, you can see that no matter how hard we try, we just can't get the DNA to amplify. Tumor testing, of course, is also at a higher cost because it uses multiple venues, and we're testing more than one specimen type. For blood and saliva, of course, it's readily available. We can use next generation sequencing and can identify mosaicism if the lymphocyte cells are involved at least 3% variant allele frequency. It is less costly, but if it's negative, in many cases, you have not completely ruled out the possibility of mosaic NF2 or schwannomatosis, and tumor testing will still be necessary. So I just wanted to highlight that mosaic NF2 has a significant overlap with schwannomatosis. So especially in patients who are not initially presenting with bilateral vestibular schwannomas or ependymomas, there can be a significant concern that perhaps they do have schwannomatosis. So for these patients, it can be necessary to use genetic testing to make this differentiation between mosaic NF2 and schwannomatosis. For individuals that have features that are suggestive for NF2, and of course, if there's an NF2 pathogenic variant identified in the blood, that gives you your diagnosis of NF2 straight away. The same is true if we see a mosaic NF2 variant present in the blood, that gives them their diagnosis of mosaic NF2. But for individuals who have a suggestion for mosaic NF2 or schwannomatosis, and we don't see an NF2 pathogenic variant in the blood, we do recommend this 3-tier approach of NF2, SMARCB1, and LZTR1 in 2 or more anatomically unique tumors. We will look for a common first hit, and any common first hit that's seen, we will look to see if they're present in the blood, and this is done in complement for specimens that are sent for NF2 testing, or for tumor testing, excuse me. So this is just an example of a report from an individual that has had tumor-based testing. As you can see, it's a much more complex report because we are discussing more than one gene, but I've created a box down here at the bottom so that you can clearly see what was seen. In this particular patient, there was an LZTR1 first event that we could clearly see. In each tumor, there is a different NF2 pathogenic variant, and in each one we saw the long arm of chromosome 22 loss. For this particular patient, this was able to confirm a diagnosis of LZTR1 related schwannomatosis. So in conclusion, just to give you some highlights of each of these different testing approaches and options, for NF1 and Legis syndrome, the assessment of mosaicism allows for a more accurate genetic counseling of sporadic patients. So this can be very helpful in helping them to determine who's at risk of passing down, what their recurrence risk can be as well. Low-level mosaicism for pathogenic NF1 variants that are in at least 3% variant allele frequency can be done with a more simple test like blood now. However, it does not eliminate completely the need for a potential biopsy-based test if this testing is negative. First-line DNA-based NGS reduces the need for a blood draw and its special precautions for RNA-based analyses. So it still allows us to identify many splicing defects, but yeah, it has its big benefits there. There is also phenotypic overlap and genetic heterogeneity amongst neurofibromatosis, and having the next generation sequencing panels available to help in patients that have more of a NF Noonan phenotype, for example, or are concerning for both NF1 and Legius syndrome. Having these panels available allows you a useful and cost-effective approach to review which condition they may have. For NF2 and schwannomatosis, the same is true about helping to determine recurrence risk and risk for transmission. We also are able to identify pathogenic NF2 variants that are present in at least 2 to 3% variant allele frequency. But again, if this testing is negative, we may still need tumor-based testing to completely rule out mosaicism for NF2. I think a lot has been learned over the past 10 years regarding the genetics of schwannomatosis and its differences with NF2. There's been a lot of overlap that we did not necessarily realize initially. And so, as Dr. Plotkin had mentioned previously, there is a need for genetic testing in some cases to help rule out whether this is indeed NF2 versus schwannomatosis. So at our lab specifically, we do suggest when there is concern of NF2 versus schwannomatosis that tumor-based testing may be the best approach. So I just wanted to take a moment to thank our laboratory director, Dr. Ludwin Messiaen, our team at UAB, who has been working very diligently on trying to provide good quality testing, and of course the patients and providers that have entrusted us with the care of their patients. Thank you.
Ok, mil gracias, doctora Gómez. Ha sido muy interesante y de verdad que es mucho lo que hemos avanzado y todavía schwannomatosis sigue siendo un enigma, pero creo que con NF1 estamos cada vez más entendiendo más. No veo ninguna pregunta todavía, déjame mirar. Estoy mirando. Creo que pronto todo el mundo está como listo para un break un poquito más largo. Yes, go ahead, Patrice.
No, I do have a question here from Moises Fiesco-Roa. Great presentation, Alicia. What are roughly the costs for the different molecular approaches of patients with NF1 and NF2? Thank you.
Sure. So for NF1, the testing ranges from $1,000 to $3,000, depending on the testing approach used. For next generation sequencing, this is closer to the $1,000 mark. For the biopsy-based testing, with the need to look at both NF1 and spread1, for example, this is where we reach the higher end of the costs. For NF2 and schwannomatosis, the range is from about $800 to $2,500. Again, this is starting with NF2 only in blood to a tiered approach of multiple tumors in for NF2, SMARCB1, and LZDR1.
Perfecto, gracias, doctora. Tengo una pregunta aquí. Doctora, si la mamá y el papá no tienen neurofibromatosis, pero la hija nació con la condición NF, ¿es probable que el segundo bebé nazca con NF?
Not typically. Because NF1, I'll start with NF1. Because it is a fully penetrant disorder, then if neither mother nor father have any signs or symptoms of disease, then the concern is that it is more likely to be a de novo, a brand new gene change that started in the child. If there are any signs or symptoms, even if it's minimal, maybe just a couple of cafe au lait spots, for example, in one of the parents, then you can be concerned about mosaicism, and additional testing can be done to rule that out. For NF2 and schwannomatosis, since these are later onset conditions, and specifically for LZTR1 and SMARCB1 related schwannomatosis, where you can see reduced penetrance, meaning that even if you have the gene change, you may not present with signs or symptoms. That's not necessarily the case, that because they have a child with one of these conditions, that they may not be of risk of passing it down to the next generation.
Okay, I see a question here from Marcela Galvez. Thank you for the lovely presentation. Would it not be difficult to differentiate a variant with a VAF of 2 to 3% from a technical artifact? Should the lab report such a low VAF variance?
So that's been a part of what we've tried to customize with our next generation sequencing approach. We use multiple amplicons. We have both forward and reverse reads, and we have other orthogonal testing methodologies that we use to help confirm these variants before putting them on a report. We also look at patients who have been on the same run and whether or not the same variant has been seen in a low level in someone that we've seen with a clear-cut pathogenic variant, to make sure that it's not an artifact that's just been on that particular run, for example. So we have a cascade of things that we do to help ensure that when we put it on the report, we feel confident that it's not an artifact.
Okay, I don't see any more questions. Thank you very much, Alicia.